In order to support our patients and communities, we need to understand issues of risk and vulnerability during disasters. In disasters, we think about risk as being the interaction of pre-event factors, event characteristics, and recovery variables that result in a cumulative exposure. An important part of developing interventions involves understanding where risk is concentrated. We can think of stressors like a toxin, such as lead or radon. And to understand risk and intervene effectively, we need to understand aspects of exposure, such as who, when, how much, the response over time, as well as the factors that buffer against it. In this way, the duration and severity of exposure to various traumatic aspects of disasters are an important aspect of risk. For instance, during COVID-19, healthcare workers involved in direct and prolonged care and exposed to extremes of suffering, as well as human remains and mass death, have been at increased risk. Though disasters can look different, they often share aspects of risk. Hurricanes displace people from their homes and neighborhoods, while a pandemic might limit our mobility and restrict us to being at home. But both can increase feelings of social isolation. A hurricane might flood or damage roads and lead to power outages, whereas a pandemic leads to stay-at-home orders and physical distancing requirements. But both types of disasters create circumstances that serve to reduce access to care. Disasters also remind us that risk is not distributed equitably. For instance, those with less financial resources or marginalized in other ways are often more likely to reside in areas more geographically prone to disasters, live in dwellings less resistant to the impact of disasters, and receive care or services from systems with less resources to manage disasters. As we've seen in numerous disasters, including Hurricane Katrina, the Flint-led water crisis, the Deepwater Horizon oil spill, and COVID-19, certain communities are disproportionately burdened by disasters. During COVID-19, one area of predictable risk associated with physical distancing requirements and stay-at-home orders we observed was a decrease in utilization of outpatient healthcare. This has led to reduced cancer screenings and other preventive services, the impact of which will be difficult to quantify for some time. There's also a significant increase in the proportion of ED visits for child abuse and neglect. It's an important reminder that our efforts to reduce risk in one area may actually increase other health risks. We also want to remember that risk changes over time. For instance, adherence by the general public to nearly all interventions intended to control the spread of COVID-19 diminished as the pandemic progressed. Understanding how risk is evolving over time for any disaster within your community or organization helps in developing more effective and targeted policies and interventions. Historically, marginalized communities experience a disproportionate burden of disasters. Structural and system issues, developmental stages, socioeconomic factors all contribute to aspects of risk. A lack of financial resources and health disparities in care create risk for some members of a community. Certain disasters expose various vulnerabilities as well. A hurricane or earthquake might damage infrastructure, including electricity, roadways, and buildings, preventing access to systems of care, and this will disproportionately impact those who rely on those very systems. First responders and emergency workers can be both victims and responders, adding to their burden of stress. The principles of disaster and preventive psychiatry can be mobilized to support these communities, benefiting vulnerable populations and promoting health equity. As we've discussed, certain populations have increased risks during certain types of disasters. Children are more prone to heat illness. Those with lower financial resources are more likely to be in transient housing or shelter facilities during evacuations or other displacement, creating a range of potential vulnerabilities. Understanding the risks of a changing global climate and how these impact certain populations enables enhanced preparedness, response, and recovery. In addition to slowing or reversing the changes in our global climate, protecting health will require systems and communities to be better prepared and to help those who are most vulnerable. Mass violence often adversely affects certain groups, often through direct exposure to death, dying, and human remains. Law enforcement personnel are trained to pursue and engage a shooter, but have to pass by wounded and dead victims in an effort to kill or capture a shooter. Medical first responders face a different dilemma when they're prevented from rendering aid to wounded victims while law enforcement renders the scene safe. In an effort to enhance care and safety for all involved, recent changes in doctrine and increased coordination between law enforcement and EMS have led to the creation of safe zones within an active shooter scene in which EMS can attend to or evacuate victims. Both law enforcement and medical first responders are exposed to a large number of killed and wounded victims, which can be distressing, and even more so when victims include children. The issue of something called psychological identification, where someone begins to think that could be my child or that could be my loved one, increases risk for a variety of negative mental health outcomes and is important to plan for through training and preparation. Medical personnel in emergency departments represent another vulnerable population, as these sites collect the injured and concentrate exposure. A study in 2017 looking at general surgery residents in an Orlando hospital following the Pulse nightclub shooting identified rates of PTSD as high as 30% in residents on call at the time of the shootings. This group remained highly symptomatic 7 months post-event. Mass violence occurring in locations previously thought of as safe havens, such as schools, places of worship, and healthcare settings, can be particularly disturbing and disruptive to a sense of safety. During COVID-19 and other pandemics before it, healthcare workers experienced concerns about not only their own safety, but the safety of their families as well. Notifying family members after the death of a patient is an area in which few healthcare workers receive any formal training. The process of death notification to surviving family members often has significant and lifelong effects, both for the family members as well as the person doing the notifying. When handled poorly, it can amplify distress and prolong grief. But when done effectively, death notifications can significantly aid in recovery for everyone involved. Limited resources and transition to crisis standards of care increased moral distress for many frontline healthcare workers. People found themselves saying things like, "It's not supposed to be like this," or "We shouldn't have to work under these conditions in a developed nation." These are all difficult issues that create risk and highlight the importance of support for healthcare workers in pandemics and other disasters. It's useful to think about how we assess risk and where it's concentrated within the population. For instance, an organization that we might work at, as well as the protective factors that are promoting resilience. And these factors aren't static, they evolve. So ongoing assessments can be very helpful to better understand the trajectory of risk and resilience. For instance, during COVID-19, organizations that have been doing ongoing assessment of their personnel have been better able to take the temperature of their workforce over time. Surveys can provide valuable information, and they can be a useful way to reach large populations, particularly when they're geographically dispersed. Within communities and organizations, key informant interviews and focus groups can also yield very useful information. Sometimes may be more attainable face-to-face and interacting directly with people who may have more time than they feel is available to complete something like a survey. And an often underappreciated method of gathering information is simply by walking around and talking with people. For instance, leaders in faith communities have long understood that the most effective way to connect with people during crisis events and to support them is simply by being present. This kind of leadership through walking around can be particularly useful to better understand the well-being of any workforce or community that's dealing with the impact of a disaster. Being with people and talking with them can also help them feel heard and appreciated, and to understand all of the challenges that they are dealing with. And that can be very helpful during a disaster. Clinical measures can be helpful to better understand the frequency of mental health disorder symptoms. We can also look at measures of human performance to better understand how people are functioning. Presenteeism, where personnel are physically present but mentally distracted, and team cohesion, as well as the experience of leadership, can provide useful and actionable information to help organizations and those who lead them better support their workforce. These type of human performance measures, which can be particularly important to quantify, depending on who you're working with and the data that you're collecting. For instance, if the goal is to determine the need for workplace changes, while it may be important to note that, for instance, 25% of the workforce is experiencing symptoms of depression or post-traumatic stress, sometimes organizational leaders are better able to understand when someone informs them that 20% of their personnel are experiencing presenteeism. Because for most non-behavioral health personnel, this type of information helps them more clearly understand the operational impact. It's also important to look for measures of resilience or even the good things that can emerge from bad situations. For instance, we could think about one segment of the healthcare workforce and other sectors of society that has been more homebound during the pandemic. For some in our society, staying at home brought increased risks of using drugs and alcohol and other challenges like family conflict. But for others, it's been an opportunity to spend more time with family and friends and get to know their neighbors or even engage in self-care. Some healthcare workers may have spent more time at the hospital and missed their family. But some may also feel a sense of meaning and purpose by playing a historic role protecting the health and safety of their communities. So whether we're gathering data or simply talking with someone impacted by a disaster, it's important to understand and acknowledge all sides to an experience that for some bring risk and others that are protective and even result in growth.